It's a great delight to represent the North of Scotland here today, and I'm representing the North of Scotland. I'm a ex-surgeon in Highland, so a colorectal surgeon to trade, and most definitely not a techie. So if there's any techie questions at the end, you're going to have to look elsewhere. But I'm representing the North of Scotland here, and I'm just glad that Orion have actually put on the weather today, because this is absolutely great. I can't remember where your Middle East guy is, because this morning I left Inverness. It was -2, and the plane was de-iced before it took off. So what I'm going to do is let you know what we're going to talk about, which is I'm going to do quite a bit of background. Because this is a UK and Ireland conference, some of you will not be aware of the organisation of healthcare in Scotland. So I'm going to do a little bit on that. Some of the existing systems in Scotland, because a lot of the stuff that we've done with Orion, with the North of Scotland portal, is dependent on the existing systems that were in Scotland. And I think without that background, you won't really understand what we've done. Patient flows in the North of Scotland, and then what we've called Care Portal, which is just a branding that we decided to use for Portal in the North, Phase 1 and Phase 2. And then this is very much my own personal opinion regarding future. This is not an Orion thing. It's not the official North of Scotland, because I'm sure there's quite a big price tag attached to it. And you'll see what I mean. So, first of all, 14 territorial health boards in Scotland. Now, you've got to remember, Scotland's a small country. Might be big in size, but it's small in population. We're probably about the size, population-wise, of Greater Manchester. But we've got 14 health boards, territorial boards. We've got Golden Jubilee as a special board, which is our waiting times board. I'll actually use the mouse. You'll see that here we've got this big orange block. That's actually where I am in Highland. We've got remote and rural area problems, because you'll see that orange block is the size of Wales, but it's probably about the 10th of the population. So we've actually got a population in that area of 300,000. Now you may ask, why on earth? Inverness is actually up about there, just in there at the Moray Firth. You may ask why we've got this bit down here, but that's probably for another day. And if there is anyone here from Shetland, just Ian's comment about maps upside down. This is something that I really hate, which is Shetland does not live just off the coast of Scotland. It is much further north. All right, and you'll see in this one here, we've got the 14. That's actually where Shetland is, which is way up there. We've got Scotland divided into sort of 3 regional areas, which are almost sort of philosophical regions. We've got the north, which is shown here with the 3 island boards of Shetland, Orkney, and the Western Isles. You've then got Highland, Grampian, and Tayside, and so that's the light blue area, which makes up a huge landmass area, but actually is only about 26% of the population of Scotland. You've got down in the west, you've got 4 boards centred around Glasgow, which make up 46% of the population. And Glasgow makes up 21% of the population in Scotland. And on the east side, you've got a wee town called Edinburgh, which actually makes up about 17%. The existing systems in Scotland have been developed over the years. And just to compare a little bit with England particularly, Scotland have lots of systems that actually share data between hospitals and between boards. But we're probably way behind England in actually developing our own systems within a hospital, just because of the way the health boards are set up. Sky Store is a Scottish Care Information Store, which was actually, interestingly, I didn't know this until I was in a car the other day, was actually bought by NHS Highland way back in 2000 or 2001. And then very quickly was bought by NHS Scotland and rolled out across the 14 territorial boards. And essentially it's a data repository. So here you can see our results section, which this patient's got, 400, sorry, my eyesight has gone, is 441 records over God knows how many years. But you'll see that it's got a smattering of lab results, all colour-coded. We've got radiology, we've got endoscopy, and If we then go on, we've also got another tab for documents. And here, this patient's got 74 documents over a number of years. And that is actually our main repository of information. Anything that is developed electronically in Scotland nowadays, the first thing is it tends to get stuck into store so that it's then accessible. The good thing is that we can actually interrogate other stores. So this is just a screenshot from Highland of the access that I have to other Sky stores. So if I've got a patient, say, down in Lothian in Edinburgh, I can log in to our local Sky store. I'll then search for the patient, then actually go to find a patient, click on Lothian store, then go into Lothian store. I've got full access to all the information that's in there. If I want another bit of information from Highland store, I've got to come back out of Lothian store, go into Highland store, and if I think, I didn't quite remember what was that bit of information from Lothian, I've then got to go back in. It's there, but it's clunky. And I think just the important thing is that we've got lots of information there from lots of different stores. The ones that I don't have access there are probably the ones that we have least interaction with just because of our geography from Highland. But it's clunky. The other thing that we've got is emergency care summary. Sorry, Sky Store's been around since 2001. Emergency care summary was developed in 2006 and has limited information. But in 2006, it was actually quite revolutionary for us in Scotland because we were actually extracting data from GP systems. So we had allergies and alerts going into a national system. Medication repeats were going into a national system, and any acute scripts in the last 90 days. That was all that the GPs would allow us at that time. They wouldn't allow us useful things like diagnoses. Because the first thing I do when I'm looking at that is think of the drug, and then I think of a diagnosis. And if you're on something like citalopram, which is an antidepressant, that's pretty simple. You've probably got depression. But if you're on something like propranolol, you may actually have a half dozen different diagnoses. And depending on what other drugs you're on, I might actually try and assume which may be incorrect or it may be correct. But that's actually information that we've got available for all health boards. And as a clinician, if you've got a clinical contact with a patient, you can access that. In about 5% of patients, GPs have actually sat down with their patients and done what's called a key information summary, which is where they've actually, patients are probably at risk of being admitted to hospital, they're frail, they're probably elderly, they've probably got lots of comorbidity. And on this slide, this is just a bit of the key information summary, which shows a lot of the diagnoses, and at the bottom, their do not resuscitate status, which in this case is resuscitate. So that's actually available. That's been available from 2006. The other thing in Scotland, we introduced PACS, Picture Archive Communication Systems, Carestream product, way back in 2007. So any X-ray that is done in Scotland, so if I go to Lothian, fall over, break my ankle, the X-ray will be available in national PACS within minutes. So when I come back to Inverness, there's no need for me to be carrying a CD or a DVD or, God forbid, actually playing X-ray films. That my orthopaedic surgeon can actually just log on to the national PACS system and get access to that. Interestingly, when I've had quite senior physician colleagues who've moved to the north of Scotland from certain parts of England, they've actually commented that lots of this stuff is really good because they don't have access to that in England, whereas personally speaking, in Highland, our electronic patient record is actually much less developed than they were used to down in England. But if patients were moving from different parts of Scotland, they got much more information. Just going to do a little patient history and just to highlight the problems of geography in Scotland. So you've got the light blue area here, which is the North of Scotland region, involving all 6 boards, 3 mainland and 3 island boards. So we'll just take a fictitious gynecology patient with postmenopausal bleeding in Portree. Now, Portree is on the Isle of Skye. Now, some of you will remember the Skye Bridge was built probably in the 90s, I think. So it's now not essentially an island, there is actually a road across. But before that, there was a ferry. That patient will then present to their GP with postmenopausal bleeding. We'll get an urgent postmenopausal bleeding clinic in Inverness, which is 112 miles away. 112 miles, I don't know if any of you have actually been to Skye, and if any of you have been to Skye in the middle of summer, and if you, God forbid, have been in either a caravan or a camper van, please pull over to let some of the locals actually past. It's a relatively slow drive. It's not, a motorway or even dual carriageway. Some of it is single track road with passing places. So that's patients got to travel from Skye across to Inverness. If they're really lucky, they might actually get history examination, a hysteroscopy, and occasionally they might actually get a CT scan on the same visit, because we try and arrange, because of our geography, we try and arrange to have slots available for patients. And they're diagnosed with endometrial cancer, but they won't actually have the diagnosis that day, but they'll have a suspicion of it. There'll then be a regional gynae-oncology MDT, which is coordinated between Grampian, which is where our main gynae-oncologists are, so the gynae-oncologist surgeons, Highland and Tayside, and it's by VC. Patient will be discussed by VC, and in this hypothetical case, and just in case there's any gynecologists about, I know nothing about gynecology, but we'll just say the radical surgery in Aberdeen, which is part of the process. Patient will then be pre-op assessed. Now, if they're relatively fit and well, that will be done by phone, by a nurse using a pro forma. If it's difficult, they might actually do a video consultation using a thing called NHS Near Me, which is probably known elsewhere as Attend Anywhere, which we've rolled out in Highland, which gives really good video consultation, browser agnostic, and you actually get the nuances of body language. If they are pretty crook, they may actually have to travel back to Inverness to get further tests done. Then they have to travel right across to Aberdeen, where the surgery is. They'll have inpatient surgery there, whether it's laparoscopic or open. They'll hopefully make a nice full recovery and then be discharged home. So that's going back right away to Skye, and then they'll be followed up with either the local gynaecologist in Inverness or with a visiting gynae-oncologist from Aberdeen who comes up periodically and does a clinic, but the patient's got to travel back to Inverness for that. Aberdeen to Inverness is about 104 miles. Reasonable-ish road. For Scotland, it's pretty good. Actually, it's horrendous for accidents, but in the winter it's interesting because you go quite high and it can be quite interesting, going across through Elgin and Fochabers. And the patient's actually also got to travel from Skye to Inverness. So that just gives you a flavour of a patient. I've already commented that Scotland is quite small. As a surgeon, I virtually know most of the surgeons in Scotland, apart from probably some of the young consultants now, because I'm coming out the other end of the consultant ladder. But we're a relatively small nation. And within e-health, we actually get on very well and collaborate a lot. The e-health leads meet monthly. The clinical e-health leads, which each board has a clinical e-health lead. Some boards, bigger boards, have 2 or possibly 3 who share a role. They meet quarterly, and then we meet up with our e-health lead colleagues twice a year. And then on a regional basis, we have ad hoc meetings. So we actually do talk to each other, and we try and work collaboratively. The main thing about regional working that really got a kick to stimulate regional working was HEPMA. HEPMA, Hospital Electronic Prescribed Medicine Administration, business case came out from the Scottish Government probably 2006-ish, 2007, somewhere around about that. HEPMA has been in Scotland, Ayrshire and Arran have it for 25 years probably, about 94. Other boards, Lanarkshire, Dumfries and Galloway and Forth Valley have also introduced it recently. And the HEPMA business case, I think, was essentially nicked from those 3 boards and promulgated by the Scottish Government. But very quickly, an addendum came out, which really very, very strongly advised regional collaboration. In the north, we actually embraced this because we thought we've only got 26% of the population. We don't have any big supersized board. And for us to get anything done, we need to work together. So we're small. And the supersized board, when I talk about Highland, we've got 6% of the population of Scotland. Tayside, which is a slightly bigger neighbour, has 8%. In Grampian, which is by far the biggest board in the north, only has about 11%. So there's not a huge difference between board sizes, although Grampian is still significantly the big brother in the partnership. Meetings happened with regard HEPMA for pharmacy, e-health and medical directors, and there was lots of willingness to collaborate. And probably the most important thing, and this is not to insult any colleagues from the Central Belt in Scotland who are here today, there are very few egos in the north. And I think that's probably, and that's not actually e-health egos, but there are probably some e-health egos, but there are also health board egos. And I think that the supersized boards in the Central Belt can actually delay regional working to a degree, so it doesn't happen in the north. So we then started thinking portal. We in the north were very slow, but we actually saw what was happening in Glasgow. And I'm interested by Gary's slide. I'm 4 years out. Greater Glasgow and Clyde. Obviously I had it along but before 2008, but they were really the forerunner in Scotland. By far the biggest board in Scotland, developed it with Orion, and then it actually spread to other boards in the west of Scotland. And they developed portal to portal, which is essentially like the Sky store to store, which I alluded to earlier on. But it is, and Gary commented about this earlier on, about trying to cover 75% of the population in Scotland. The problem is you're still doing portal to portal. You're going from one system into another, and in patient context, which is great, but it's clunky. And we'll show you what we've done in the north. And at that point we thought, well, if we're collaborating so much about HEPMA, and HEPMA was going to be one system for the north of Scotland, and that is actually progressing, we thought, well, why not we do one single portal for the north of Scotland? So we then started discussions in 2017 for one for the north. The question would be then, who would host it? Highland, being fairly small, didn't want to host it. Tayside were sitting on the fence because from the map you'll see that Tayside is a little bit sort of foot in the north camp but a foot in the southeast camp, and they sat very squarely on the fence, so that left Grampian. So Grampian actually had the ability and the space to host the servers, and Orion then managed the application. So we actually was on-prem in Grampian, which actually was the first one that we've worked in the north of actually having e-health professionals working collaboratively together between boards, which has its problems, but it needs to be worked out. And there's a great appetite, particularly amongst the e-health leads. And that's probably the most important thing, is that the leads are very much back in this to the hilt. And they, I was going to say they pull their hair out, but the two actual leads, particularly in Grampian and Highland, don't actually have very much hair. They probably actually lost it. But they get vexed by the fact that their staff don't embrace collaborative working as much as they should do. But that is changing. And it's the fact that we've now got more face-to-face meetings actually in the room. So if you've got a specialist doing, I won't even name the types of specialists, but if you've got one specialist in Highland and another one in Grampian or another one in Tayside, if they actually meet face-to-face, they actually work much, much better collaboratively in the future. Initial boards were Grampian, Highland, Orkney and Shetland. Tayside, purely because they couldn't make up their mind whether they go north or south. But they've now actually made a decision and they're actually coming in. Tayside's slightly different because Tayside historically were probably by far the most advanced e-health-wise in Scotland because they did a lot of in-house development. But that has now ceased and they're now coming on to mainstream products. And they actually had an in-house developed portal themselves, which they then couldn't support. But that's one of the problems with their decision making, that they had to rationalise that they need to come off their own in-house portal and then come to the Orion portal. So they've now actually come on board. Western Isles, you'll see, is another board that's out on its own just now, but I'll come back to that. We've just branded it NHS Care Portal. We did have some really stupid suggestions, but thankfully none of them came to fruition. And what was the boat that David Attenborough boat? That's the very one. I think there was variations on that coming through, but thankfully we've just gone for Care Portal. Care, we had thought of clinical portal, but we actually want this to be care as in health and social. All right, we're not there yet, but that's what our aspiration is. And you'll notice also that there's no health board logo in there, apart from this. The NHS with a funny thing underneath it is just a bog standard NHS Scotland logo. But normally under that we'd have Highland or Grampian or Tayside. But we've actually taken away all the thing, and we've taken away any regional thing, and we just put it as Care Portal, which might be relevant for the future, and probably my last slide. So, phase 1. A unified view of Sky stores from Grampian, Highland and Shetland. So we've actually got 3 Sky stores in the north. Shetland has got an independent one. Not a lot of patients from Shetland we get to Highland. Orkney share their Sky store with Grampian, so they're actually an offshoot of Grampian, hence collaborative working already, and Highland. And that, I'll show you a screenshot in a minute of what I mean by unified view. Clinical encounters from 2 track care, so Grampian already host the track care intersystems product for Shetland and Orkney. Emergency care summary, PACS images, and a link to Glasgow portal. So this is actually a live gynae patient. It's not the one I showed earlier on. This is actually a lady that had ovarian cancer and was diagnosed in Highland, went to Grampian. And this just highlights, the blue is information in Grampian and the red is information in Highland. The good thing about this is the patient summary down the left-hand side of Care Portal, and all I need to do is click on any of these and I bring up the document. So if I'm looking at this anaesthetic record down in Grampian, I just click on it and they've already scanned that anaesthetic record. They don't have the anaesthetic record electronic, they haven't developed their theatre system to do anaesthetics electronically at the moment, but when they do in the future, that will just go in there and we then know what's going on. Patient had a resting ECG in Highland, and that was part of their pre-op workup. So therefore, there's no point in Grampian having to repeat that, because it's there. They can see it. They can interpret it themselves. The ECG machine does a report for them, and as a colorectal surgeon, it's great. It's the best thing that happened to ECG machines. It stopped colorectal surgeons misinterpreting ECGs. You'll see here that we've got various letters from gynecology, from Grampian, and also from Highland, all in the one place. And this is where I have to emphasise the fact that this is not portal to portal. This is much, much smarter. This is, for a clinician, it's brilliant, because you see all the information there and you're not faffing around going from portal to portal, or in past what I used to do with Sky Store to store. Clinical encounters. What I've done is highlight this patient again. The blue boxes are Inverness, the red boxes are Aberdeen. So you can see what's happened to this patient from their clinical encounters in Care Portal, all on the one screen. Phase 2, which we're embarking on presently, GP data. Now, just in case, sorry, I'm just going to have a quick drink. Just in case you think that everything is rosy north of Hadrian's Wall, it ain't. I sat down with our GP subcommittee back in June of 2017 with a GP data sharing agreement, which I'd nicked, as most people do. I'd nicked it from another board that had already done it. So Lanarkshire had a really good data sharing agreement with GPs that they'd managed to agree, so that they got information from GP systems, loaded it into Portal, and it was then instantly available to clinicians in secondary care. We'd worked as a short life working group for about 6 months with GP input, and at that GP sub in June of 2017, the chairman was going around the committee saying, right, everyone seems to be in agreement, are we happy to sign this? And the secretary then said, you do realise that there's a BMA embargo on local data sharing agreements. Oh, bugger. So that was that scuppered. So there was then national work on a data sharing agreement. And that was 2 years and probably 5 months ago. And in the last 2.5 years, we've had, it's almost finished. It's almost finished. And there's been very heated debates, particularly at the combined meetings between the health leads and the clinical leads, because the clinical leads are just pulling their hair out. They want the GP data. And GPs are actually keen to give it because they say, you know, they're wasting time answering questions from secondary care when the data could actually be visualised in secondary care. But from what I am assured is that it's gone to the Information Commissioner in Scotland, it's gone to our central legal office in Scotland, and apparently it is due before Christmas 2019. I put in 2019 just in case if you're too cynical. I thought it might be 2020. But that is, you know, that's been a disaster. You know, our information governance is obviously very important, but our information governance colleagues have really sadly let us down there with actually faffing about, discussing individual words and not actually taking a holistic approach. We want social work data. That's actually in the North region. Grampian are going to lead on that with working with social work colleagues. Again, why reinvent the wheel? So we've nicked what Glasgow have agreed with their social work colleagues as a starting point. And what we're hoping then is that we will get social work data into our care portal. And the problem is that we've got quite a number of different local authorities to work with. Highland is coterminous, so we've just got one local authority, whereas Grampian have about 2 or 3 and different social work systems. NHS Tayside are coming on board. There's lots of work going on with Orion and Tayside just now to get them on board. And we're hoping that that's going to be finished within probably, I would hope probably about the next 6 months to 9 months. It was probably about a year-long project. So there is work ongoing to get them on board. One of the problems is that Tayside, as I said, they developed lots of in-house systems and they want the same functionality in Care Portal as they had in their own bespoke portal. Care Pathways. So far, we've been using Care Portal purely as a viewing portal. That's all. We haven't embraced any of the actual doing within portal. What Care Pathways we want to exploit, and we're very keen to work collaboratively with other boards in Scotland, Northern Ireland or England to actually lift and shift and take things from other boards and actually put them into the North portal. Okay. Collaborative work lists. I use my only clinical activity is endoscopy, so I use personal work lists a lot. There's only 6 of them, but I've used 6 of them for my endoscopy, so all my results, I just automatically put them onto a work list. But collaborative work lists is something that we've got in our test environment just now. We'll hopefully go live with it fairly soon. And when I've talked to clinical staff about it, they're actually really excited about it, because there are, when I was appointed as a colorectal surgeon back in August of '99, one of the first things I did was put up an Excel spreadsheet in a shared drive with my secretary, because I was the only colorectal surgeon at the time, for all the patients that I thought had colorectal cancer, so that I didn't lose any of them. So if I scoped someone and I thought I saw something, I would put them on a spreadsheet straight away so that I didn't lose them. That spreadsheet is still being used now, 20 years later, with now not me, but 5 colorectal surgeons doing that, and probably about 5 or 10 secretaries using it. So collaborative work lists will be a godsend. But there is some clinical risk with collaborative work lists, one of them being that someone can delete it, and that would be a disaster. I think that Orion need to take that on board, that we need some security, that you need to, do you really want to delete this? Are you really, really sure you want to delete this? There has to be something on that, because I can just imagine if I was trying to sell this to my colorectal colleagues, and someone inadvertently deleted that work list for colorectal cancer, I would have my guts to play with. Launching other products from Portal. We in Highland see Portal as being our main clinical system where people will go into and then launch other things like our digital dictation. We've got no intention, I'm not sure if I do digital dictation, but we've got a digital dictation system which is great. We've worked with the company for the last 10 years. Just launch that in context. Get people to be in clinic, just launch it, dictate, and then use also voice recognition in the future. Signing letters, being able to get notification that you've got a pile of letters that are ready for signature. Launching things like Track Care, launching other products. The Western Isles Sky Store, I commented that Western Isles is a small population, only about 30,000. They've actually done an awful lot of really good work on their TOD using systems that they've worked with. They've maximised the benefit, have tweaked them a bit to try and work for their environment, so that because they've got a lot of patients that come to Highland, but also down to Glasgow and also Golden Jubilee. But from a Highland perspective, it'd be great for us to be able to incorporate the Western Isles Sky Store, and I think Highland will probably actually just fork out, Nick, for that cost, just on our own, because it would be such a bonus for Highland. So we don't have to do Sky store to store. And the last one, which I won't say very much about, cloud hosting, because I know very little about it and I'll get it wrong. So when Tayside come on board, because they're slightly bigger than us, they want to fight with Grampian about who should host, and the obvious thing is that cloud hosting, which would be brilliant for us. So, the future, and this is the health warning, this is my own personal view, which I think probably shared a good part with the rest of the north of Scotland. Not quite sure for the rest of Scotland, but I'll wait and see what kind of response I get from the right-hand side of the audience here. If cloud hosted, could other non-North of Scotland boards come on? And the interesting thing about that is you're then not talking about portal to portal. You're talking about actually just having one record, and it doesn't matter whether the patient's got some records in, I won't name boards, but in other parts of Scotland, it would mean that they would have access to all the records without having to do portal to portal. This might be slightly contentious. If it's cloud hosted, could we actually go for a national system? We're only 5.5 million people in Scotland. We've been hamstrung by the fact we've got 14 territorial boards. We're now actually working much more as 3 regions, and it just seems logical if we can convince some of our bigger boards and neighbours to actually embrace it. And that is being talked about actively. Care pathways, we need to exploit this and actually go hell for leather at it and actually turn off the paper production and get clinical care being recorded electronically at the point of care. We're talking, nursing documentation is a good example. Every time there is anything possibly happens wrong to a patient's care, someone comes up with a great idea. We'll introduce another A4 bit of paper with lots of tick boxes. And the nursing documentation has just gone exponential in the last decade or even 2 decades. So the Chief Nursing Officer in Scotland acknowledges this and is working with Highland. Grampian are doing some work with DHI about rationalising documentation. And we've actually done some pilots on an orthopaedic ward of all places for some documentation, and I've actually radically stripped it down. Like, the red pen, it was a paintbrush rather than a pen, and it was just completely slashed the documentation. So we're actually working on that. We're trying to roll it out to other wards just now, and then hopefully we'll try and get that into Portal, and then actually get that used in the north of Scotland. Lots of other things with care pathways that we really want to exploit. Progress notes, actually, turning off the tap of paper. Medicines management IDL in Highland, we've got a crashing problem. Our local IDL system is going out of support next year. We've seen the medicines management from Aaron on a couple of occasions. He came up kindly to Highland about a year ago, did a demonstration, and we thought, yeah, probably 2, 3, 4 years away before we would get involved. But we've just seen, because of our ideal predicament, we've just seen demos of it recently, again from Aaron, but also from Glasgow, who have this. And it is slick, particularly the medicines management bit is really, really smart. And we're really keen to progress that.